Good evening, sir. Good evening, Dr. Kushal, sir.
Yeah, good evening. Good evening, Supma.
Yes. Sir, can we start by 7 p.m.?
Yeah, I think we have still have got 2 minutes left.
Yes, sir. Yes. बंद करें. Sir, shall we start?
Yes, I think it's 7. We can start if our first speaker is ready.
Yes, sir. Ma'am, too.
Yeah, hello, Dr. Savinay.
Good evening, sir.
Good evening. Good evening. So, are we okay to start?
Yes, sir.
We
Yes.
have the required number of attendance and all.
Yes,
So,
sir.
hello everyone. Welcome to this midweek academic program, which is organized by the International Association of Integrated Oncology, uh, which is a purely an academic organization. And today we will be talking about various aspects of treatment of lung cancer. And as you might be knowing that the treatment of lung cancer paradigm is changing almost every quarterly, and we have new guidelines, new molecules, and new mutations coming up, and we are finding benefit with new drugs, with new combinations, and what is standard of care today may be outdated by another couple of years or so, and what is today what we are having as standard of care was not there 2 weeks back. So without further ado, I would be like to introduce. We have got a very elite and knowledgeable group of faculties who have volunteered today to, guide us through this program. And we will be having Dr. Savinay R. Thigia. She is a consultant, a medical pediatric and hemato-oncologist, practicing at Blood and Cancer Institute in Surat. I welcome Dr. Savinay Thigia. And thereafter, we have Dr. Arindam Mondal, who is a senior consultant, surgical oncologist, trained at TMH Mumbai and currently practicing at Manipal Hospital, Mukundapur, Kolkata. Then we have Dr. Sayan Das, who is a senior consultant of radiation oncologist, uh, and who is also practicing along with Dr. Arindam at Manipal Hospital, Mukundapur, Kolkata. And then we have Dr. Sudip Das, who is a very senior consultant, previously at AIMS, New Delhi, and then after in TMH in Mumbai. And now he is practicing in Manipal, Kolkata. He is a medical and hemato-oncologist. So welcome, Dr. Sudip, Dr. Orindam, and Dr. Shayan. And then again, we have our very elite Dr. Shuma Devraj. She is a consultant medical oncologist from Sholapur in Maharashtra. I welcome you all the panelists also, and I welcome all the faculties and the speakers for this midweek academic program. So without yeah, throughout the program, we'll be discussing about advanced stage 3 and 4 lung cancers, and we'll be also talking about the surgical oncology perspectives in stage 2 and stage 3 lung cancer, as well as the role of radiation in advanced lung cancer, followed by a quick panel discussion on negotiating clinical conundrums in advanced lung cancer. and thereafter we'll be having the closing remarks. So without further ado, I would like to invite Dr. Savinay Ardighia from consultant medical oncologist at Blood and Cancer Institute, Surat, to give her first talk in advanced stage 3 and stage 4 lung cancer, the medical oncology perspective. Dr. Savinay?
Yes, sir.
Yeah, you can take the screen.
Okay. Are my slides visible?
Yes, we can see your stage 3 and stage 4 non-small cell
Okay.
lung cancer, the green colored slide.
Yes, sir. Okay, sir. So good evening, everybody. Thank you so much, IAIO, and thank you, Kushal sir, for introducing me and welcoming me. The topic for my talk today is stage 3 and 4 non-small cell lung cancer, and I will be restricting myself to the medical oncology perspective. Okay, so without wasting much time, I would like to start my presentation. Okay. So what this deck covers, it will be covering the disease framing, including epidemiology, histology, staging, biomarkers, strategy for stage 3 and stage 4 lung disease, and supportive care. So now discussing the epidemiology, 85% of all lung cancers are non-small cell lung cancers, and it is the most common cause of mortality among all the cancers worldwide. But the sad part is that 50% of the patients present with metastatic disease, which is stage 4 at presentation. And in India, specifically, this percentage is much higher. And we have hardly 20 to 30% of the patients presenting in stage 1 and stage 2. Histological subtypes of non-small cell lung cancer can be subdivided into 3 types: adenocarcinoma, squamous cell, large cell / not otherwise specified. Among these 3, the most common type is adenocarcinoma, which has a particular characteristics that it is located in the periphery, that is in the outer 1/3 of the lung parenchyma. And these subtype, these adenocarcinoma tumors have highest yield for targetable driver mutations. The second most common is squamous cell carcinoma, which is associated with smoking per se. These tumors are more central in location. Driver mutations are uncommon here, but we get 5 to 10% of our driver mutation positive cases from squamous cell. And the very important clinical part in this is we have to avoid bevacizumab because because trials found that there was high risk of bleeding with bevacizumab. So we restrict the bevacizumab in adenocarcinoma only. And the third most common type is large cell / not otherwise specified, which is a very poorly differentiated. And here we treat as non-squamous pathway if applicable. Now, this is the TNM staging. I won't be going in the details of this, but we must know that recently the 9th edition got a certain changes with respect to the N2 nodes and with respect to the metastatic staging. So for N2, now we have N2A and N2B, that is N2 single station or subcarinal, and N2B is multi-station nodal involvement. Now for stage 3 NSCLC, it is a very heterogeneous spectrum. And broadly, it can be divided into 3 parts. One is resectable, second is potentially resectable, and the third one is unresectable stage 3. Now, what comes in unresectable stage 3 is, first of all, if the patient is having N3 disease, that is, there is contralateral mediastinal, contralateral hilar nodes, or ipsilateral supraclavicular or scalene nodes. Second, if the patient is having N2 bulky disease, that is, the size of the node is more than equal to 3 centimeter in size. And the third can be N2 invasive disease. So if there is any of these 3 things positive, then it is unresectable, and these patients are potentially candidates for concurrent chemoradiation, ideally. And if not fit, we go with sequential chemoradiation. Now, stage 3 disease, which is having N1 disease or N2 single station, can be easily operated, and rest all becomes the potentially resectable cases. Every stage 3 disease, before starting any therapy, must be discussed in a multidisciplinary tumor board setting. Now for stage 4, we have subdivided into stage 4, A, 4, B. Now stage 4A has been again divided into M1A and M1B. So M1A is intrathoracic spread, means the patient is having either cytology positive pleural effusion or pericardial effusion, or there are pleural pericardial nodules, or if there are contralateral nodules. M1B means there is extrathoracic metastasis, but it is limited to a single distant organ, which we consider as a potentially oligometastatic disease. And M1C becomes stage 4B when there are multiple extrathoracic metastases. Now, how do we stage the patient accurately? So first is the imaging. Ideal method in current scenario is to get the whole body FDG PET CT scan done. But in some centers, if we can't get the PET CT done, then for practically, we also get the contrast enhanced CT scan of thorax, abdomen, pelvis with bone scan. But nowadays, the preferred one is PET CT. Secondly, brain MRI. So any patient who is having neurological symptoms, or if the patient is having node positive disease, or the primary tumor is more than equal to 4 centimeter in size, then it becomes an indication to get the brain imaging done. Now, tissue biopsy, ideally we get the core biopsy, and the location of the tumor decides the modality of biopsy. For example, if the patient is having a hilar mass, then we can get the bronchoscopic guided biopsy. If the patient is having a peripherally located mass, then we can get the CT guided biopsy done. Now, mediastinal staging, the latest criteria which we follow has suggested that if the patient is having clinically N0 disease, the tumor size is less than equal to 3 centimeter, and it is located in outer 1/3 of the lung, then we can get away without doing the mediastinal staging. In all the other cases, we have to get the mediastinal staging done. And the ideal method which we follow is to get the EBUS or EUS done. But if the FDG PET CT scan is positive for nodal disease, like positive for mediastinal nodal disease, then even if the EBUS or EUS is negative, we do get the mediastinoscopy done. Now here comes the most important part, which is the molecular profiling. So ideally, which is recommended is to get the tissue NGS. The NGS should be a broad panel NGS, and it should cover both DNA as well as RNA NGS. Along with this, we get the PD-L1 tested for every lung tumor cases. And then we have to assess the fitness of our patient. So most commonly, we get the 2D echo done, and also a PFT and DLCO if we're planning radiation. Now, biomarker testing is very important, especially in stage 3 disease. Ideally, we get the broad panel done, but if the patient is like not affording that much, then we get at least the lung panel done, which is the 10 to 12 genes, which include EGFR mutation, ALK rearrangement, ROS1 fusion, BRAF, KRAS G12C, MET exon 14 skipping mutation, RET fusion, NTRK mutation, HER2 mutation, and then the PD-L1 testing. Now, PD-L1 testing is being done by immunohistochemistry method, and that is a membranous staining. One very important thing is, even if we get the PD-L1 result, which we usually get in 5 to 6 days, and which comes as like 50% TPS, but NGS is awaited, then we must refrain ourselves from starting the patient on immunotherapy until we get the driver mutation results available. So in lung, what is used is a tumor proportion score, which is basically the percentage of the tumor cells which are stained positive by PD-L1 upon the total proportion of the tumor cells. So that is the PD-L1 TPS scoring, which we use in lung. Everywhere else, we use the CPS. Now, for resectable and unresectable disease, like unresectable disease, I have already told the 3 criteria where we prefer the definitive concurrent chemoradiation, ideally with a platinum doublet. And then there comes the consolidation part, which we'll be discussing in the upcoming slides. For resectable disease, there are 2 methods. First of all, we can get either the neoadjuvant chemoimmunotherapy, which is the CheckMate 816 data which we have, or we can get the perioperative chemoimmunotherapy done, where we complete the chemoimmunotherapy part before surgery. Post-surgery, we continue our patient on adjuvant immunotherapy. Surgical resection, I won't be discussing in detail, which will be taken care by my senior, Dr. Arindam Mondal, sir. Adjuvant therapy, and which includes chemotherapy, immunotherapy, or even targeted therapy. Now for perioperative immunotherapy, we have 4 trials. The first is Checkmate 816, which used just 3 cycles of neoadjuvant nivolumab, 360 milligram 3 weekly, with a platinum-based chemotherapy arm. And the latest results from this trial showed that there was improved PCR, which was 24% in the experimental arm versus only 2% in the control arm, which had no nivolumab. And there was improved overall survival as well as event-free survival. The 5-year overall survival was 65% versus 55% in the control arm. The second is the Keynote 671 trial, which combined perioperative pembrolizumab, 4 cycles with chemotherapy, followed by surgery, followed by the rest 13 cycles of adjuvant pembrolizumab. This was the first trial to show an overall survival benefit. Similarly, we have the EGN trial and Checkmate 770, which used durvalumab and nivolumab respectively. Now, why we tend to give the neoadjuvant or the perioperative chemoimmunotherapy? Because of multiple reasons, as we know, as it downstages the tumor, there is some synergy between chemotherapy and immunotherapy, as chemotherapy will release neoantigens, which will subsequently increase the efficacy of the immunotherapeutic agent. It will treat the micrometastatic disease early. It will improve the pathological complete response rates. And the most important thing is in the neoadjuvant setting, the compliance of the patient is better than if we give the same therapy in the adjuvant setting. Now, why we have to test the drivers first, even if it is potentially resectable? Because we found out that EGFR and ALK positive tumors derive little benefit from perioperative IO. And here we favor upfront resection followed by adjuvant chemotherapy, followed by a targeted agent if the patient is eligible for that. Now, what comes into adjuvant systemic therapy? First of all, chemotherapy. So there is this LACE meta-analysis, which has the 5-year overall survival results, of which showed us that the absolute overall survival benefit at 5 years was roughly 5%. So what we prefer is 4 cycles of cisplatin-based doublet for resected stage 2 to 3. There was benefit if the tumor size was more than equal to 4 centimeter. So for adenocarcinoma, we prefer pemetrexed and cisplatin. And for squamous cell carcinoma, we prefer gemcitabine with cisplatin or paclitaxel with cisplatin. Adjuvant immunotherapy, if the patient was upfront operated and then received 4 cycles of chemotherapy, there are 2 trials which states that 1 year of adjuvant immunotherapy can improve further outcomes. So one is the IMpower 010, where atezolizumab was used. Every patient who had a tumor size of more than equal to 5 centimeter with PD-L1 of more than equal to 1% received atezolizumab for 17 cycles. And it found out that the hazard ratio was 0.48 for DFS and 0.47 for overall survival. Second is the Keynote 091, which used pembrolizumab for tumors more than equal to 4 centimeter in size. And this was regardless of PD-L1. And it did show a statistically significant EFS benefit. Now, there comes a targeted therapy. If the patient is having EGFR mutation, which is EGFR exon 19 deletion or EGFR exon 21 L858R mutation, ADAURA trial showed that giving osimertinib at 80 milligram once daily dosing for 3 years for resected stage 1B to stage 3A tumors did improve the disease-free survival, where the hazard ratio was 0.2, and it also improved the CNS disease-free survival. Similarly, for ALK rearrangements, we have this ALINA trial, which used alectinib at the dose of 600 milligram twice daily for 2 years for resected ALK positive disease, like for stage 1B to stage 3 disease. Here, the comparator arm was 4 cycles of platinum-based chemotherapy. So this trial did not made the adjuvant chemotherapy part compulsory for the patients, and it did have DFS benefit. Now, definitive concurrent chemoradiation, that is the treatment of choice for stage 3 unresectable disease. Now, why concurrent? Because there came out to be a 5-year survival benefit of 5.7% as compared to sequential chemoradiation. What is the concurrent chemotherapy? What is the concurrent chemotherapy which we most commonly use? If the patient is having adenocarcinoma, pemetrexed with carboplatin, pemetrexed with cisplatin, or we can even use paclitaxel with carboplatin. Paclitaxel at 50 milligram per meter square and carboplatin at AUC 2 weekly, followed by 4 cycles of pemetrexed maintenance after completion of CTRT. If the patient is having a squamous cell carcinoma, then we can use cis-itopo or paclitaxel carboplatin. So what is the position of sequential chemoradiation at present? Only in the patients who are unfit for concurrent radiotherapy. Now, after this CTRT, to improve the outcomes, there were 2 trials. One is the Pacific and second is the LAURA trial. Pacific is for non-driver mutated NSCLC who did not progress after concurrent chemoradiation. Within 42 days of completing CTRT, these patients were put on 1 year of durvalumab, which was at the dose of 10 milligram per kg 2 weekly or 1500 milligram 4 weekly. So that is the Pacific trial which showed that the median OS was 48 versus 29 months. The comparator arm here was the placebo actually. And median PFS of 17 versus 5.6 months. Similarly, for EGFR mutated NSCLC, after CTRT within 42 days, patients were put on osimertinib as per the LAURA trial. But here the duration was until progression. And they found out that the patients had statistically significant PFS benefit. The median PFS was 39 versus 5.6 months. Now for stage 4 NSCLC, the goals of our management includes prolonging the survival of patients, controlling symptoms, and as well as balancing the toxicity. So here I would like to discuss that the most common driver mutation in the West was found to be KRAS mutation. And in that, the most common was G12C. And in Asians and in our population, the most common mutation present is the EGFR mutation. So EGFR mutant NSCLC, it's a very broad topic, but I would like to cover it in a nutshell. That in the West, it was found to be in the proportion of 10 to 15%. But in our population, we have it around 40 to 45% of mutations, which are EGFR mutations. The 2 most common are the EGFR exon 19 deletion and exon 21 L858R. Then comes the exon 20 insertion mutation, and then there are uncommon mutations like S768I mutation, G719X mutation, and L861Q mutation. So what is preferred at present is using the 3rd generation EGFR TKIs. As per FLAURA trial, either alone. But what we are practicing nowadays is the FLAURA 2 regimen as per the latest results, which is combining osimertinib 80 milligram with 4 cycles of cisplatin-based chemotherapy. And then we can continue the pemetrexed arm along with the osimertinib until progression. Then there is the latest Mariposa regimen, which is amivantamab with lazertinib. And nowadays, we don't have the lazertinib access so easily available. So most of us can even combine osimertinib with amivantamab. Between FLAURA and FLAURA 2, I would like to just say that if the patient is having liver metastasis, if the patient is having concomitant TP53 mutation, or if the patient is having brain mets, then preferred is to start the patient on the FLAURA 2 regimen rather than using the FLAURA regimen, which is osimertinib alone. For exon 20 insertions, we have the Papillon trial recently, which states that using amivantamab with pemetrexed and carboplatin resulted in good results, which had OS and PFS benefit. Now, at progression, if the patient was on EGFR TKI, ideally every patient should be rebiopsied and he should be restaged. We must find out whether the patient has oligoprogression or a diffuse metastatic disease, and rebiopsy to find out the mechanism of resistance, if it was an on-site target resistance or if it was an off-target resistance. Most of the patients who progress on 1st and 2nd generation EGFR TKI generally have the T790M mutation, where as per the AURA trial, we can use osimertinib. And most of the time, if the patient has been put on osimertinib upfront, then the most common resistance mutation was the MET exon amplification actually. So for ALK rearranged, now as per the CROWN trial, the preferred one is lorlatinib, giving 100 milligram once daily. And we have beautiful results of this trial. At even 7 years latest results, the median PFS was not reached. So anybody who can afford.
2 minutes left for the session, ma'am.
Okay, I would try to cover it. So, okay, so with good CNS efficacy. Then there is this ROS1 RET NTRK and MET alteration. We can use crizotinib and entrectinib for ROS1 fusion. But recently we are using repotrectinib and taletrectinib. For RET, we have the selpercatinib, 160 milligram to be given twice. NTRK fusion, we have larotrectinib and entrectinib. And the MET exon 14, we have the capmatinib and tepotinib. For BRAF V600E, ideally, we have to use a chemoimmunotherapy regimen in the first line setting. If the patient progresses on chemoimmunotherapy, we can use dabrafenib with trametinib. For KRAS G12C also, we start our patients on chemoimmunotherapy. And if they progress, they can be used, they can be put on adagrasib 600 milligram dose. And for the HER2 mutation, we have the Destiny Lung result, which showed that trastuzumab deruxtecan worked wonderfully here at the dose of 5.4 milligram per kg 3 weekly. Now this I will cover in a nutshell, that if the PDL1 is more than equal to 50% and if the patient is not fit for chemotherapy, then we can put our patients on single agent immunotherapy. And here we have approval for 3 drugs, which is pembrolizumab, semipilimab, and atezolizumab. For 1 to 49% chemoimmunotherapy, for less than 1%, either chemoimmunotherapy or dual checkpoint inhibitor. And the approved one is giving nivolumab with ipilimumab as per the Checkmate 9LA and Checkmate 227 data. So these are the trial. I won't be going in the details for that. And I would like to skip this also. Yeah, this is a very important thing which I would like to discuss is oligometastatic disease. So up till 3 to 5 metastasis, if the patient is having, we may manage the patient on a curative intent where we can use a local ablative therapy like stereotactic radiation surgery. Plus in combination with definitely a systemic therapy if there is a targeted mutation using target or at least a chemoimmunotherapy. So for CNS meds, right now we have good agents which can cover the CNS part also, like the 3rd generation EGFR TKI, the 3rd generation and the 2nd generation, the ALK TKIs. So for a resistance, as I already mentioned, we have to restage. What is the method? What is the where the patient progressed, and we also have to rebiopsy. This is managing the immune-related adverse events. Most of them can be managed, except the sometimes it can be fatal, like in case of hepatitis or myocarditis. We should be vigilant while monitoring our patients on immune checkpoint inhibitors. And yes, a very important part is we must integrate the early palliative and supportive care that did show improved quality of life, and this should be done from the very beginning. Apart from the therapeutic options which we have discussed with our patient, the palliative care has also to be discussed. We must advise every patient of ours to for the smoking cessation also. So I would like to end here. Sorry if I exceeded my time.
So thank you, Dr. Savinay Digya. Thank you for covering that, lung cancer extensively, starting from the diagnosis to molecular testing to therapeutics and ending up with the icing on the cake of palliative care. So without further, we can take the questions in the last.
Yes.
Yeah, so I think we can take the questions in the last, Dr. Savinay.
Okay, sir.
Yeah, so our surgeon, Dr. Arindam Mondal, he is waiting actually. So he will be talking about stage 2 and stage 3 lung cancers and the surgical oncology, the finer aspects. So over to you, Dr. Arindam.
Thank you, Kushalda. Yeah, I'll just. Okay, at the outset, thank you to Dr. Kushal Gupta and IAIO for giving me this opportunity to present on the surgical management of lung cancer. I've taken a liberty to just change the topic a little bit because I saw stage 2 and 3, which are a little different in their management. The stage 2 becomes quite straightforward, but 3 is again a Pandora's box kind of. So we'll just go through them as we go ahead. As this has already been discussed by Dr. Dikia, that a very less percentage of our cases do come in the curable stage 1 and 2, and more so we find in 3 and 4s with a very different 5-year overall survival. Now coming to the nodal stage, already again discussed, I'll just go in very briefly that for surgical management, this becomes a very important criteria. This here we have taken an example of a left lower lobe primary lesion, and anything on the left hilar nodes will be called N1. Anything in the subcarinal or the ipsilateral paratracheal nodes become N2 nodes, and anything in the contralateral hilar paratracheal or the supraclavicular nodes become N3. So now where does the role of surgery come in? One, of course, for the mediastinal staging, that is using mediastinoscopy. And we'll discuss about the tussle between EBUS and mediastinoscopy in the following slides. And for curative resections, which can be a lobectomy, of course, with the systematic mediastinal lymph node resection, or sublobar resections like segmentectomy or wedge resections. Also touching upon briefly on extended resections, where we have, which is basically T4 lesions, which can still be managed with curative surgery. Now, why stage the mediastinum? As again been pointed out by my previous speaker, the 5-year survival takes a completely different turn when there are mediastinal nodes which are positive, which from localized to regional nodes drops from 52 to 24% as per the study by Bosema. However, even after the staging, how many of these patients do we find to have unforeseen N2, which is basically we have done the surgery thinking it is N1 disease, and during the mediastinal lymph node dissection, the post-op biopsy shows that there are nodes present in the N2 stations also. In terms of that, if we see that is around 12.5% unforeseen N2, despite all the staging. So now what are the options we have? Of course, is EBUS with biopsy or mediastinoscopy. The EBUS, as has been discussed, is the lesser invasive one, and so the first option which we have. And of course, this gives us a very good uptake depending on on where we are practicing. So what has to be taken into account is also our own institute strengths in terms of EBUS, the yield, and the positivity. If we persist, there is a learning curve even in this as an institute, and so we need to see where we stand in order to advocate for EBUS alone without mediastinoscopy. Mediastinoscopy, it is a surgical procedure under general anesthesia where mediastinoscope is used to look at the nodes in the mediastinum and take either resection, complete resection, or sampling from them with a very less false negative rates, but of course with a significant amount of complications, especially in terms of rectal laryngeal nerve palsy or bleeding. Now, this has been the bone of contention that after an EBUS has been done, and of course, if that is positive, then it directly gets labeled as N2. If it is negative, then do we need to do a mediastinoscopy to confirm whether it is actually in mediastinal node negative disease or not? So this MEDIAS trial, which came up a few years back, which basically compared EBUS. They did for patients first EBUS. Whoever were negative, one group were taken for directly surgery. The other group underwent confirmatory mediastinoscopy, and then after that they went ahead with surgery if that also showed there were no N2 disease. However, at the end of it, when they saw the number of unforeseen N2, which is after surgery, how many of them are now showing N2, the numbers were very similar between these two groups. So that is, as shown here, 9.6 versus 9.9. So basically, then our confirmatory mediastinoscopy is not helping, particularly in selecting these patients. So since the difference was less, along with the morbidity, they recommended that it can be bypassed also. But of course, this has to be taken along with, as I said, our expertise of EBUS in our institute. And if that is less, then of course, and mediastinoscope obviously is available, then it should be included. Now coming to the treatment options. So yes, of course, surgery is the treatment of choice in the early NSCLC. Other options being various forms of radiotherapy or RFA in unfit patients. Now, who is exactly a surgical candidate? So easy part is if it is T1 to T3 up to hilar nodes, basically ipsilateral nodal disease N1. That covers our in stage 2 disease also. Now coming to stage 3, basically where there are certain T4 disease like which are invading not non-essential body parts like the chest wall, pericardium, or the diaphragm, which can also be resected completely. Also some N2 disease, where it is basically N2A. There's a single station N2. Of course, this is first treated with neoadjuvant chemo, and in today's terms, neoadjuvant chemo immuno. And then, provided there is good downstaging, these patients can also be candidates for surgical resection. And as in the previous talk we heard, oligometastatic disease only if it is very localized, and the resection can be affected at both both or two or three places, whatever. Most commonly we find it lung with solitary brain met. These are the ones which can be very easily treated with surgery plus minus, or in various combination of radiotherapy, SBRT, and surgery. So these can also be the surgical candidates, provided again there has been good response to initial systemic therapy. Now, this decision of surgery for these patients does not depend only on the radiological findings, only not just on the operability based on the CT scans, the PET CT scan. Also, yes, on the mediastinal nodes as we saw, and also the patient's ability to stand withstand surgery, which is we assess it through various tests, which we'll see. But one of the main ones is the pulmonary function test, where we know if there is a right upper lobectomy for a right upper lobe lesion which has to be done, how much is the predictive post-operative FEV1 and the DLCO which is there. If that is significant, then we can go ahead. So coming to the anatomical ones, which we have already seen, these are the which are not including any of the vital mediastinal structures or the vertebrae, and of course no N2 or N3 disease, and these are the exclusion criteria. And in terms of the evaluation, of course, effort tolerance. One of the easy ones which we ask patients is how many flight of stairs are they able to climb. That gives us a eyeballing of the pulmonary function test and a proper FEV1 and a DLCO assessment. Also, sometimes in borderline cases, we take help of the 6-minute walk test. And although the most gold standard test basically is the cardiopulmonary exercise test, which basically assesses both the lungs and the heart together to look for the operable fitness for surgery. These are some of the acceptable values. So basically, after removing the part of the lung, if there is at least 40% FEV1, or actually the cutoff is around 30%, unless it is a diseased lung where it is a 40%, that is good enough for the patient to carry out their day-to-day activities even after the surgery. And it's very important to have a close communication between the anesthesiologist and the pulmonologist in these cases for the prehabilitation, before the surgery, during and after the surgery, because of the lung function reduction because of pain. So in prehabilitation, of course, smoking has to be stopped as soon as the diagnosis is made, if not earlier. And then chest physiotherapy with incentives spirometry to improve the lung functions, nutritional rehab, and bronchodilators if required, depending on the status of the lungs. Now, during surgery, what are the principles which have to be very meticulously adhered to? One is, of course, a complete tumor resection. R0 resection. Along with that, a very important part is the adequate lymph nodal staging. So here we see the various mediastinal lymph nodal stations, and a systematic mediastinal lymphadenectomy is a very important part of every lung cancer surgery. Without which we do not have exact data basically on the post-op biopsy to decide on the correct form of adjuvant treatment. And along with this, what is also important is to preserve as much of lung parenchyma as possible. So this is especially because most of these patients are old patients and they may have borderline lung functions. And of course, immediate post-op morbidity has to be reduced as much as possible from the surgery. So yeah, the challenges being most of these are old patients with pre-existing COPD and smoking history in most cases. So the pulmonary rehabilitation becomes very important. After the surgery, because it is a thoracic procedure, the pain in the chest most of the times causes hypoventilation. They take short breaths rather than deep breaths, causing atelectasis, which can lead to pneumonia. So now the finer aspects of surgery comes in, where we have moved from the days of open thoracotomies to more minimally invasive surgery, which basically causes much less pain, leading to faster recovery and as much of lung preservation as we can do. So these are the two aspects which we'll see, the MIS and the lung preservation part. Of course, the extent of surgery, the gold standard is still a lobectomy. Here we see a right upper lobe lesion, right middle lobe lesion here in the right lower lobe, for which we did a Watts right lower lobectomy with the SMLND. However, when it was seen whether anything sublobar resections, basically limited resections for very small tumors, how do they fare as compared to lobectomies? This was not very encouraging, because it showed that anything lesser than a lobectomy, like sublobar basically is segmentectomy or wedge resections, they showed a very high local recurrence rates, and which ultimately led to high increased cancer-related deaths in this cohort. But when we look, when we dissect this sublobar resections, we actually find they comprise two very different surgeries. One is a segmentectomy, where if it's a small lesion, it fits the criteria which we'll discuss. The entire segment is removed. So like here are the lung segments shown. If it is a less than 2 centimeter lesion in the, say, the left upper lobe, in the apical segment, then just an apical segmentectomy can be done with mediastinal lymph nodal resection also. However, a wedge resection is just cutting off a wedge of lung with the tumor, which is good enough for metastasectomies when there is a metastasis coming from other organ. But because lung cancers flows through the lymphatics into the nodes, so this is not a very ideal procedure. And if we take out the wedge resections, then actually comparing segmentectomies with lobectomies, we find the results are not that depressing. So why do we want segmentectomies? Because yes, we are removing, instead of, for example, a right upper lobe, complete lobe, which comprises of 3 different segments, we are removing only the apical segment, which is one segment, which reduces the amount of lung which has been reduced. So that translates to better quality of life and less morbidity, especially in the old age people who have less borderline lung functions. But then it is a technically more demanding surgery, and regarding the long-term outcomes, there were a lot of doubts regarding it. So we come to these 2 landmark trials. One is the Japanese trial by Asamura, where they compared only lobectomies with segmentectomies, and they found that the 5-year overall survival was very much similar in between these two. And this was, of course, in a very early stage setting, the patients who were eligible for segmentectomies. And local recurrences, although they were a little higher, but they were not statistically very significant and did not have a long-term adverse outcome in the survival. Similar results were seen in the CALGB trial with a similar OS. Now, where do we can we have this segmentectomies in that case? Of course, it has to be along with the hilar and a mediastinal lymphadenectomy has to be done to be very sure that there were no N2 disease, because that is one of the criteria. There has to be an N0 disease, and it has to be a peripheral less than 2 centimeter, and we should be able to take at least more than 2 centimeters of margin on the tumor during the segmentectomy. So if these criteria are met, then a lobectomy in the borderline fitness patient is as good as a lobectomy. And of course, for everything else, it is lobectomy with SMLND. And a close follow-up is required to look for any local recurrences. Now, that is about the amount of lung which is resected. Now, the approach. So this was our age-old posterolateral thoracotomy through which we access the lungs. As you can see, we're going through multiple layers of muscles here, the latissimus dorsi, the serratus anterior, and then we access the lungs. This causes a lot of pain in the post-op period, leading to the post-op pain and decreased lung ventilation and the rest of the problems. So now we have shifted to more of VATS and RATS, which is basically video-assisted thoracoscopic surgery. This is one of our patients where through a very small incision to remove the tumor from the body. Apart from that, there are only small holes through which the entire tumor can be excised. leading to less pain. Duration of this intercostal drain, which is given the ICD, that can be removed within day 2 of the surgery, reducing the duration, and that reduces the pain also, which again leads to less atelectasis, less pulmonary complications, and of course becomes more safe in the geriatric population. And of course, if there are complications after surgery, the adjuvant therapy gets delayed or sometimes even negated. So that also translates to better post-op adjuvant care.
Sorry to interrupt, sir. 2 minutes left for the session.
Okay, thank you. So multiple studies which have shown that they are as good as open lobectomies in terms of survival. And in terms of now coming to robotic surgery for lung lobectomies, there again, when these were compared with VATS, it showed that it were almost similar in a lot of things, including a 5-year overall survival. But better in terms of disease-free survival was robotic. And of course, less blood loss and less conversion to open. Also, that extended resections which I was talking about, suppose there is a lesion in the left upper lobe which is extending into the main bronchus, then a sleeve lobectomy can be done where a part of the left main bronchus is removed and then these two are joined back together. Similarly, on the pulmonary artery, sometimes if it is stuck, the part of the patch of pulmonary artery can be removed and reconstructed. These can be possible with the better vision of robot. And post-tumor where these are extended resections again. Some of the examples how robotic technology helps us to achieve this. This is intraop image of, this is a pulmonary artery basically, which is supplying the upper lobe, which we dissect, and then with these are the robotic staplers. Very easily this can be resected without any blood loss. Similarly, there's something called a Firefly technology where we are doing a segmentectomy, where out of this entire lobe, we want to remove only one segment. So we have taken out the blood supply to that segment, and now ICG dye is given. And when we see, we can see exactly the part of lung which is getting supplied by ICG, which is the alive part, and the part which is dead already because the blood supply has been taken. That is marked, and along these lines, the resection is carried out. After this, we carry out the resection on these lines. So the parenchyma is preserved. And I'll end with just a surgical video which can carry on by the time if there are any questions which are coming on. This is a right side bilobectomy. It was a right middle lobe lesion which was extending into the lower lobe for which the resection was carried out. And yes, so this is how the resection goes. These are the pulmonary vessels. This is a vein actually to the lower lobe, which is being dissected out here. And after this, this is the right lower lobe, inferior pulmonary vein, which is isolated. And then the staplers are used in order to resect these. And so this very easily, without much of blood loss, resects the vein. Similarly, with the nodes are dissected and the arteries are taken. In the final stages, the parenchyma is taken. This is the bronchus, basically to the right lower and the middle lobe. I'm sorry, this is the artery, the continuation of the pulmonary artery. And similarly, after the parenchyma is taken, we take the bronchus. This is the bronchus which is being isolated. And once that is done, once this has been isolated, we inflate the lung in order to see that only the upper lobe is inflating very well and the lower lobe is not. And after that, it is transected, thereby removing the entire lower lobe. And then the mediastinal lymph node dissection is carried out after that. That's all. Thank you.
Thank you, Dr. Arindam. Thank you for the wonderful lecture on the surgical aspects. And thank you for all those videos of surgeries. So, any questions if anyone wants to ask? So I don't think that there are any questions in the chat box right now. So maybe we can just get those questions later. And next speaker, I would like to request Dr. Shayan Das to take the stage for explaining to us the role of radiation in advanced lung cancer. Dr. Shayan Das.
Good evening.
Good evening. Good evening.
Yeah, so at the onset, I would like to thank Dr. Kushal Gupta for inviting me and giving me this opportunity. Thanks to the organizing team as well. So I think it was an excellent talk by Dr. Arindam regarding the surgical aspects. Now I would discuss the radiotherapy perspective, especially for advanced lung cancer. So let's just see. Can you see my slides?
Yes, sir.
Fine. So the first thing is, why discuss radiotherapy in advanced non-small? I'll be mostly limiting my talks to limiting my deliberation on non-small cell lung cancers. Now, historically, the outcomes aren't great despite offering chemoradiotherapy in advanced lung cancers. And for stage 4, that is for metastatic tumors, it was conventionally mostly systemic therapy alone. However, in the last decade or so, management of, I think, some of the tumors, like especially lung and breast tumors, they have undergone a sea change, and the outcomes have improved drastically, which brings into the role of any consolidation in metastatic set scenarios. And we would like to see whether the outcomes have improved even for stage 3 lung cancer. And what I would going to discuss is radiotherapy is now relevant across the disease spectrum. So just a broad overview of what we will be looking at while discussing this is mostly this multi-station N2s, that is the N2Bs and N3s. So mostly 3B and some 3As. This is what we'll be discussing for in advanced lung cancer, as well as its role in metastatic scenarios. Now, stage 3 lung cancer is a very heterogeneous group. If you look at this diagram on the right side, if you see some stage 3s, they are resectable, which would undergo a surgery. Some are borderline resectable, and there comes the role of some form of neoadjuvant therapy for downstaging and then undergoing surgery. And there's a small group which again belongs to stage 3, but it is unresectable. So it's mostly, if you see the multiple station N2s, the N3s with a T4 disease is mostly what are the unresectable ones. And I would just show one audit data, again slightly older data, but even for stage 3 disease, even in a country like UK, less than 5% of 3Bs and around 1/5 of 3As actually undergo surgery. Most of them would receive radiotherapy with or without chemotherapy. Now, how to manage stage 3 lung cancer is a very challenging thing. You have to keep in mind several things: the patient factors, the tumor factors, about how fit the patient is, not only pulmonary function, but cardiac functions, his performance status, comorbidities with regards to tumor. So where are the nodes, the number of stations involved, is it technically resectable? So these several factors have to be taken into account before we decide whether we're going to plan for surgery or a non-surgical modality. If you look at the ESMO guidelines, where radiotherapy is playing a part is mostly the N3s and the unresectable multiple station N2s. Otherwise, if it is resectable, the primary treatment option still remains surgery followed by adjuvant therapy. Now, for N2s, there are several randomized trials comparing role of surgery versus radiotherapy. And honestly, we don't have a definite answer because there is none of them have shown to be better than the other. There is some benefit after with regards to PFS in the intergroup study, but the other studies like EORTC and SPATU did not show any survival benefit with any of these local therapies compared to the other. So in an unselected population, surgery may not improve survival compared to chemoradiotherapy. And we have several such studies. We have a meta-analysis, which also kind of says that you need to select your patients appropriately before you decide the treatment. Does induction chemotherapy help? Well, again, there's this CalGB study which showed that induction chemotherapy followed by chemoradiotherapy versus upfront chemoradiotherapy, again, no difference in outcomes. So if you're planning for chemoradiotherapy for a patient who you deem is unresectable, there is no point in delivering neoadjuvant to all comers. So if I just give one example, such large tumors where, as a radiation oncologist, if I find that delivering tumoricidal doses would be difficult to such large volumes and I don't expect a complete response, I would definitely consider downstaging or shrinking the tumor with neoadjuvant chemotherapy. But otherwise, routinely, no, we don't. What about the doses? Standard doses for chemoradiation for radiotherapy is around 60 grays. People have tried giving higher doses. Again, this is a landmark study, the RTOG 0617, which actually showed that your outcomes are worse if you're trying to deliver higher doses. You end up causing more toxicity. So standard dose still remains 60 gray in 30 fractions. And for fit patients, we prefer concurrent chemoradiotherapy. However, those who are not suitable would end up receiving a sequential one. Studies have shown that CTRT is better than a sequential chemoradiotherapy. There is a significant improvement in overall survival if you offer them together. Now, as I said in my very first slide, that historically the outcomes with chemoradiotherapy for stage 3 has been not great, is what I would say. It was, if you look at the median survival, it is hovering around 2 years. However, things changed with this game changer study, the Pacific trial, where after chemoradiotherapy, patients were offered 1 year of maintenance immunotherapy with durvalumab, and never before seen almost a 20 months benefit, so 29 months versus close to 48 months when you add immunotherapy for 1 year. So this has now become the standard of care. So for advanced lung cancer, if you're offering chemoradiotherapy, do consider adding maintenance immunotherapy for a year. The benefit was seen across all subgroups, irrespective of the histology and the PD-L1 status. So for all comers, that is the standard. The major toxicity concern remains is pneumonitis, especially when you offer radiotherapy. Radiotherapy itself increases the risk of pneumonitis. When you add immunotherapy beyond that, there's a significant risk. Almost, say, 1/4 of the patients did have significant pneumonitis. So you must keep this in mind while planning for that. Once people got excited about durvalumab, they thought, why not add durvalumab along with chemoradiotherapy, which was tried in Pacific 2. However, it did not show any significant benefit. Following Pacific 2, now there is data that if you have EGFR mutated tumors, you can have maintenance osimertinib, and it has also shown a significant benefit and has now become the standard. The ASCO guidelines again says if you see after concurrent chemoradiotherapy, patients with an EGFR exon 19 deletion or exon 21 mutation should receive a consolidation osimertinib. For other patients, they should receive a consolidation durvalumab for up to 12 months. Now let's come to the second portion of the talk is, can radiotherapy help in patients beyond stage 3, first in stage 4 patients? Now there's this concept of oligometastasis. That is, when you have a limited metastatic disease, this concept came in 1995. This kind of something, an intermediate stage in between a localized disease vis-a-vis a florid multiple sites. So something is a state in between. So where the disease has spread beyond the thorax, however, it is still limited to certain sites. Some sites only. There, your locoregional therapy or consolidation therapy may have a role. Now, a lot of debate about how you define. Some say up to 3 metastases, some say up to 5 metastases. But the thing is, it should be limited. again, oligometastasis is a mixed bag because for a de novo, so patient presenting upfront with a limited metastasis, there we may aim for cure. The other thing is patients having multiple metastases on systemic therapy, and I find that most of the sites are responding well. There is a progression in limited sites. There, if you add some consolidation radiotherapy, you can thereby delay uh, your second line therapy and thereby improve a quality of life. So these are the two possibilities where radiotherapy can have a role even in a metastatic state. So how RT can help is it can eradicate your resistant clones. So if you're having progression at a limited site, those resistant clones can be taken care of by adding ablative doses of radiotherapy and thereby prevent further metastatic seeding. You can delay systemic progression. And there have been some reports, case reports of abscopal effects. Again, it's a very minimal role. So bottom line, important thing is you have to treat the limited disease aggressively so as to have a better systemic control. What about evidence? Again, evidence is still evolving, mostly phase 2 data. Only one, the CINDA study by Wang et al. Is the only phase 3 randomized study where in EGFR mutated non-small cell with having 4 or less metastasis, TKI plus radiotherapy versus TKI alone did show an improvement in overall survival as well. Saber Comet is the often quoted study, but it's a phase 2 where it did show a significant improvement in overall survival, 50 months versus 28 months. However, it's a phase 2. The phase 3 Saber Comet is still ongoing. We await the results. CARP trial, again, I'm discussing this because pretty interesting data. This was done for oligoprogressive metastatic cancers limited to breast or non-small cell lung. What was interesting is it did not show any benefit for breast cancer, but it showed significant benefit for lung cancers. So the CARP approach says that if you're having progression at limited sites, target only those resistant clones so as to have a better or a prolonged systemic control. North Star, again, people are excited about this data because it's a phase 2 study where in EGFR mutated non-small cell, osimertinib versus osimertinib plus local consolidation, and you have a 40% reduction in the risk of progression with minimal toxicities. So exciting data, but the role of local regional radiotherapy for a metastatic case is still evolving, I would add. Adverse events, if you plan properly, you say it is less than 2 to 3%. Where SBRT is actually shining is in patients where you have good systemic therapy. So you have patients, so EGFR mutated patients who would do well for a prolonged period on osimertinib, or patients who are doing well on immunotherapy. There, if you are having progression at limited sites, it is those scenarios where you're adding consolidation radiotherapy or ablative radiotherapy is going to be helpful because you can delay your next line of treatment and thereby maintain quality of life. So ideally, good performance status patients having a controlled primary, limited disease burden, not more than, so I would prefer something less than 3 mets, but people say up to 5 mets can be considered. Again, fluoride mets, poor performance status, rapid progression, they are definitely not candidates for SBRT. What does ASTRO and ISTRO say nowadays is that for oligometastatic cases, do consider local regional therapy for patients up to 5 metastases. NHS policy, I often discuss NHS because this is a publicly funded health program. So before they recommend, they usually check out whether it is actually effective or not. And what does NHS say is that they have reviewed the evidence and they feel that there is enough evidence to make the treatment available at this point in time. for so it is again, what is the proposed, the way I think is for a stage 4 disease, start off with systemic therapy, reassess after a few cycles. If you're having partial response or stable disease having limited sites, you can consider consolidation SBRT. But the best scenario would be oligoprogression, where you add SBRT to the progressing lesions while continuing the same systemic therapy. So my takeaways would be that concurrent chemoradiation remains the mainstay of treatment for unresectable stage 3 disease. Consider maintenance durvalumab, as it improves survival significantly and has become the standard of care. Oligoprogression is the area where there is upcoming role of adding SB, because it can delay your change in systemic therapy. Radiotherapy is now influencing outcome across the advanced non-small cell lung cancer spectrum. However, bottom line, patient selection is the key. Thank you.
Thank you, Dr. Shayan, for that wonderful talk on the role of radiation. And thank you for the wonderful slides and the detailed explanation of the role of radiation in oligometastatic lung cancers. And it was quite enlightening, actually. And now for the last part of our, I don't think we have got any questions in the chat box. So we can take those questions later. And for the last part of our talk, I would like to invite Dr. Sudeep Das, who is a senior consultant of medical oncology and hemato-oncology at Manipal Hospital in Mukundapur, Kolkata. Dr. Sudeep, I would like to invite the other panelist, Dr. Shuma Devraj. She's a consultant of medical oncologist at Solapur, Maharashtra. Then I would like to invite Dr. Shayan Das, we just heard his talk. And I think Dr. Arindam Mondal had to leave due to some complications, to check on a patient actually. So he will not be joining us, but together we, along with Dr. Sudeep Das, I don't know, is Dr. Digya there? So maybe we can just me, Dr. Shuma, and Dr. Shayan and Dr. Sudeep Das himself, we can conduct the panel discussion on negotiating clinical conundrums in advanced lung cancer. So Dr. Sudeep Das, the stage is all yours. Thank you for joining.
Yeah, thank you, sir, for giving me this opportunity, and thanks to IIO for giving me this platform. I request organizer to operate my slides from their end. May I have my slides?
Yes, sir.
Yes, please. So we'll be discussing that how in bedside clinic, how we take decisions while treating in advanced stage lung cancer patients, and are we restricting non-small cell lung cancer? Next slide. So, when in stage 4 non-small cell lung cancer patients come to your clinic, there are different clinical and histopathological, there are different issues, factors which actually guide us that what should be the best or optimum treatment strategy for this patient. And in solid organ, if one solid organ which has evolved as a perfect example of personalized oncomedicine, then it should be lung. In last two decades, we are witnessing a lot of precision medicine in treating advanced non-small cell lung cancer, and also we witnessed a lot of improvement in outcome of advanced lung cancer because of the use of immune checkpoint inhibitors. But how to make the decision whether to start immune checkpoint inhibitor or whether to start TKI molecule and we actually how to detect the actionable driver mutation. So there are a lot of issues there. So may I ask my panelist, Dr. Suma Devraju, for ma'am, while you are treating your patients, advanced non-small cell lung cancer patients, what are the clinical factors among these which are shown on screen you give most important?
So good evening, sir.
Yeah.
When treating any patient with advanced lung cancer, a combination of all these factors I would take into consideration to decide on the treatment. So based on histology, whether it is a squamous or non-squamous histology, and also performance status of the patient.
Correct.
Uh,
So, do you test molecular test in squamous and adeno both, or you are sending molecular test for only adeno?
So in my practice, both squamous and non-squamous, as per NCCN guidelines, I'm testing molecular status in both.
Right. What about Dr. Dr. Kushal, sir,
Yes.
what is your practice? Are you sending a molecular test panel for squamous and adeno? Like Dr.
For squamous, I'm mostly doing only EGFR with PCR, and for adeno, I'm sending the 15 gene molecular lung molecular panel.
Yeah, yes. So at least EGFR and ALK should be done in squamous. But yes, often there is the histopathology is adenosquamous, so we may miss, but that is not a common variety. But there are good series and case reports of detecting, EGFR and ALK even in squamous histology. And regarding molecular test, Dr. Suma, what molecular test you are doing?
I'm sending the comprehensive NGS lung panel for most of the patients.
Okay. We have other panelists like we have Dr. Shayan Dash. Dr. Shayan, though you are not a medical oncologist, you are a radiation oncologist, but to detect the actionable driver mutation, how you want to proceed your patient? Suppose you mentioned LAURA trial, which showed significant benefit of prescribing osimertinib maintenance after definitive chemoradiation. So suppose you want to give the benefit of LAURA. So how you want to test the patient? What are the test method you will apply? Dr. Shah.
So, yeah. So, for EGFR, you would need a PCR. For ALK-ROS, I mean, IHC-based methods are there, but I think for confirmation, you would require a FISH.
Sorry.
I think only PDL1 you can get through IHC.
I see. Right. And what is your point? How important is smoking history while treating a stage 4 non-small cell lung cancer? Why it is important? What is your take on this, Dr. Shah?
So smoking history is definitely important because one of the few of the things, one is, so I think the lung patients that we often see, they usually have some underlying COPD, some pulmonary diseases. So smoking again would lead to further reduction in their lung function status. With regards to response, so I think there is some correlation that the smokers, they tend to have better response with immunotherapy. So I think there is, I mean, especially if there is squamous with smoking history, I think there is some approval of offering immunotherapy irrespective of the PD-L1 score or something like that. So probably for the patients having a history of smoking, uh, although the chances of having driver mutations is relatively less, but probably the response rates with immunotherapy are slightly on the higher side.
Correct. So, yeah, uh, absolutely correct. And there is also, please previous slide, please. The previous slide. Yeah, also the disease burden is previous. The previous slide. Previous slide. Yes. Also, important factors are disease burden because whether the patient has multiple skeletal metastasis or he has visceral mets also, that is also very important. Site of metastasis, if the patient has brain mets, that is important. And if there is brain mets, then how many numbers brain mets and what is the location of those brain mets? And of course, it also depends on the treating physician's experience. And nevertheless, the most important are that all medical oncologists they prefer to look at the endpoints of response rate, PFS, and OFS. Next slide. So, Dr. Shayan, he was mentioning that PCR is one of the tests and which can pick up EGFR mutations. So, EGFR is not only the only single mutation, there are different mutations are picked up, and more than 50% of stage 4 non-small cell lung cancer are biomarkers, though a large chunk of that is KRAS, and for which we don't have any very good efficacious drug in first line setting. But even if you consider KRAS as one of the driver mutation, then 50% of stage 4 non-small cell cancer have biomarkers. Next slide. And how to test them? Either you can do PCR like what mentioned by Dr. Kushal and Dr. Shayandas. We are often doing PCR for EGFR. You are doing FISH for ALK, right? We are doing FISH for ROS1 and IHC for PDL1. But what is the importance of doing a NGS? Next slide, please. So, if you look at this NGS report very carefully, this report came to my mail yesterday night only. If you read out the report date, it is 16th of June 2026. And this report, NGS report, just came to my mail last night, and it showed that the patient has EGFR mutation. It has EGFR mutation exon 19 insertion and also a T53 mutation. Now, suppose this was a EGFR exon 19 deletion and a coexisting T53 mutation. There is a lot of there is a clinical implication is completely different than a EGFR only deletion. Next slide. So, the FLAURA2, which is osimertinib plus chemotherapy, this strategy has clearly shown an overall survival benefit. Look at the median overall survival. It is the delta is 10 months, 47 months versus 37 months with a hazard ratio of 0.77. At 4 years, there is 8% increment in overall survival with osimertinib plus chemotherapy compared to only osimertinib. And this strategy is more helpful if the patient has brain metastasis upfront or the patient has coexistent mutations like T53. So it is better to do a NGS so that we can understand that what is the patient has compound mutation, and this patient is an ideal candidate for FLAURA2 regimen. What is your opinion, Dr. Suma? Dr. Suma.
Sir, this patient has co-mutation of TP53. So normally, when there is TP53 mutation positive, we consider patient to have poor prognosis. So based on this FLAURA2 data, where results are very good in patients who have brain mets and TP53 mutation also. My option for this patient, if affordable, would be to start the FLAURA2 kind of a treatment with osimertinib and addition of chemotherapy.
Yes. So we know that T53 patients, they are poor prognostic patients. That clone is not going to do better with only TKI. So we need some cytotoxic drugs. Suppose the patient is not, the patient does not have access to osimertinib. Dr. Kushal sir, will you not treat this patient with a gefitinib, the first generation TKI plus chemotherapy in presence of such kind of compound mutations? And these compound mutations are not very less common. They are quite prevalent. Dr. Kushal sir.
Yes, definitely. If the patient does not has got logistical issues for osimertinib, then definitely we can give gefitinib along with chemotherapy to this patient.
Yes, yes. Thank you, Kushal. Next slide, please. Like this trial, which is phase 3 top trial, this was all about EGFR and T53 mutations, coexistent mutations. The trial design was osimertinib plus chemotherapy versus osimertinib only, and it was a phase 3 trial. Next slide. And this trial clearly showed, look at the PFS difference, it is doubled. 15 months versus 34 months. The PFS was doubled with osimertinib plus chemotherapy. Benefit was consistent across all the subgroups, including those with CNS metastasis or L858R mutations. Now, let me explain that L858R mutations are prognostically little worse than exon 19 deletion. Next slide. We have seen the importance of doing NGS. Now, suppose the NGS is um, picking up ALK mutations, and suppose what should be your best first-line treatment of choice? Patient has access to every drug. Again, I will come to Dr. Kushal sir.
Yeah, so as the graph clearly shows by the Crown study, that lorlatinib has got good amount of brain penetration with manageable toxicities, and so it should be definitely be offered to the patient, patient of ALK mutated brain mets.
Yes, thank you. My next question will be to Dr. Sayan. Dr. Sayan, Dr. Sayan, are you here?
Yes, I'm there.
This 5-year follow-up data from Crown trial shows that the 5-year PFS rate is 60%. Please note, these are not West curves. These are PFS curves. At 5 years, the PFS rate is 60%, and hazard ratio for PFS is 0.19. How impressed you are with this data?
I mean, this is fantastic data. And more importantly, if you see, so at 2 years, the PFS was 70%, and at 5 years, it is 6. So the curve is almost a straight line. So those who are surviving beyond 2 years, they are having an excellent local control, disease control. So,
Yeah, I repeat, these are PFS curves. These are not even OS curves.
but even then, so I mean, beyond 2 years, those was, not progressing beyond 2 years, they tend to have an excellent result. So fantastic data, no doubt about it.
Thank you. My next question will be to you, that if such patient is coming to you with a brain metastasis, are you willing to treat this patient with SRS?
So this is about lorlatinib. Now, nowadays, what I practice is, if it is an asymptomatic brain mets and patient is going to receive lorlatinib, then no, I will not offer radiotherapy to the brain. To back up my opinion, I would quote. So recently this was presented in ASCO this year, trial from TMH. Professor Anil Tibdewal did that randomized phase 3 study, ABM trial. So that was for EGFR mutated patients. So randomized trial between upfront radiotherapy to the brain, which is SRS, versus observation and then treating when the patient progressed or became symptomatic. No difference in survival outcomes. So if you are providing systemic therapy with a good CNS penetrance for asymptomatic patients, do not offer radiotherapy.
And in that TMH trial, all the patients, they were offered the third generation TKI like osimertinib or lorlatinib.
I need to check, but most of them. So again, so this was not lorlatinib because it was mostly EGFR mutated, as far as I remember. It was only for EGFR mutated. Or I think no, I think it was irrespective of any driver mutation having. So they did not offer first generation TKI. So most of the patients did receive either osimertinib or lorlatinib. So patients having mostly they received. I need to check, but I mean, most of the patients did receive, so they included EGFR and ALK, and most of the patients did receive osimertinib, I believe.
Okay, okay. So my next question will be to Dr. Suma. Dr. Suma, you know, being a medical oncologist, you know, the lorlatinib has neuropsychiatric manifestations as is a part of the adverse effect profile, lorlatinib. And yes, and you also know it has an excellent intracranial efficacy, disease control rate. So in such patients, exposing them to radiation may increase the chance of CNS toxicity. Will you refer this patient to a radiation oncology colleague if the patient has access to lorlatinib?
So, sir, I think Crown trial, lorlatinib, when we see the curves, even for intracranial disease, those patients with brain metastasis, lorlatinib is an excellent drug with compared to all the other ALK TKIs, lorlatinib has maximum intracranial efficacy. And considering that PFS of 60% at 5 years, the patient is expected to live for a long time. So I would offer lorlatinib first because the longer they live, again, the quality of life should also be maintained.
Thank you. Thank you. Again, I will start from you, Dr. Suma, that if the patient has come to you with an IHC report, which is available within 7 days, and the IHC showing ALK, and we all know that IHC has a good concordance, more than 80% for ALK. Are you still sending NGS or you start treatment on the basis of IHC?
As in that situation, maybe I would send an NGS, sir. Though IHC is
Yes.
good
Next
enough,
slide,
but I
please.
would like to confirm.
Yes. Next slide. Yes, correct. I will come to this point later. So this is the PFS in patients who had upfront brain metastasis. Look at the separation of curves. The hazard ratio for PFS in patients with baseline brain metastasis, the hazard ratio is 0.08. Unbelievable hazard ratio, 0.08. Look at the separation of curves. Next slide. Yes. And look at the incomplete intracranial response rate in patients who had measurable brain metastasis at the baseline. The complete intracranial response rate was almost more than 50%. They showed complete response in brain. So, next slide. Yes, this is important. Just like there is an NGS is more valuable in treating a EGFR mutated patients. NGS can be valuable for treating ALK patients also because all ALK mutations are not same. There is variant 3 ALK mutations. They are prognostically poor. Look at the data of variant 3 ALK mutations. For for standard patients ALK mutations where the hazard ratio with crizotinib for PFS, the median PFS with crizotinib was 9 months. When the ALK mutation is variant 3, the PFS with crizotinib drastically drops down to 5.6 months from 9 months. And look at the PFS of variant 3 with lorlatinib. In others type of ALK mutations, it was not reached, but here it is 60 months. So variant 3 is poor, prognostically poor subgroup, but still lorlatinib has significant efficacy in variant 3 also. So that is the importance of, you know, of doing NGS, even though IHC can pick up report. There are some, maybe there are some patients use, you may be very happy that IHC report is showing ALK. We may explain the patient that your prognosis is excellent. We may start with crizotinib and the patient may progress within 5 months. Next slide, please. And there is also data that T53 mutations coexistence with ALK also affect the final outcome. Next slide. And in presence of coexistent T53, lorlatinib has better, PFS benefit compared to crizotinib. Now I'll come to a case with without any actionable driver mutation. If the patient does not have any actionable driver mutation, we have multiple options. We can use KEYNOTE regimen, we can use CheckMate 9LA, we can use ADCP regimen, Paclitaxel, Carbo, Bevacizumab, Atezolizumab. Dr. Kushal sir, what is your favorite and why? If you are treating these patients with IO, is it chemo plus IO or IO-IO combination?
No, so Dr. Sudeep, my patients don't afford IO-IO combinations actually. So I go with the pemetrexed carboplatin for adenocarcinomas, and with or without, depending on the TPS score, without addition of IO, pembrolizumab, that too through the scheme that patient support program and all, if they are affording. Otherwise, just chemotherapy alone.
Thank you, Rushana. I will ask again to Dr. Shayan. Dr. Shayan, do you believe that IO-IO combination has advantages over only IO? One IO?
Again, no clue.
Dr. Suma, do you offer IO-IO combination for any subgroup of patients? You will explain that you are the right candidate for dual IO combination rather than treating them with only one IO.
So, sir, I think almost all the IOs have kind of a similar result, but if PD-L1 is negative, then maybe, but still Pembro also has equally good results.
Yes. KEYNOTE trial has clearly showed that even in PD-L1 less than 1%, there is significant overall survival benefit. Yes. Next slide. So this is the study design. The CheckMate 9LA study design was in control arm. You are continuing the patients with maintenance chemotherapy, but in intervention arm, you are giving Nivo every 3 weekly, ipilimumab every 6 weekly, but chemotherapy is administered only in first 2 cycles. After the first 2 cycles of chemotherapy is stopped. So patient has chemo-free interval after 2 cycles of initial chemotherapy. Next slide. Look at the study patient characteristics. 20% patient in this trial, they had upfront CNS metastasis. This is important. Next slide. Look at the PD-L1 score distribution. Almost 40% patients, 40% patient in this trial had a PD-L1 expression of less than 1%. Next slide. There is clear-cut overall survival benefit, OS benefit, with longer follow-up. Look at 5 years. The overall survival is percentages surviving percentage 18% versus 11%. So almost 1 out of every 5 patients without any driver mutations are still surviving with dual IO plus initial 2 cycles of chemotherapy regimen. Next slide. And what Dr. Suma rightly pointed out, look at the data of PDL1s for less than 1%. This survival advantage is even more prominent in patients who had PDL1 of less than 1%. At 5 years, 22% patients are surviving. Next slide. Look at the duration of response in PDL1 less than 1%. With chemotherapy, the curve of PFS curve drastically falls, and the median duration of response with chemotherapy in PDL1 for less than 1% patient is just nearly 4.3 months, whereas that is 17.5 months of duration of response with dual IO Nivo plus EP in patients who had a PDL1 score of less than 1%. At 5 years, the duration of response, durable response rate was 25% when the patient's PFS rate was PDL1 score was less than 1%. Next slide. Is there any unmet need with brain metastasis patients? I repeat here, Dr. Suma correctly pointed out that one group of patients who are eligible for IUIU regimen is PDL1 less than 1%, but there is clear-cut benefit of this strategy in patients who had brain metastasis. Next slide. Look at the OS advantage in patients with baseline brain metastasis. In patients who have upfront brain metastasis at 3 years, the OS rate is 28%. Median OS with IUIO is 19.3 months versus only 6.8 months with chemotherapy only in patients who had brain metastasis. Next slide. This is intracranial PFS in patients with brain metastasis at 3 years. At 3 years, 14% is the intracranial PFS rate. Intracranial median PFS is 11.4 months with IUIO versus only 4.6 months with chemotherapy. So I think we have come to end of our discussion. Next slide. And this is OS advantages in brain metastasis population. Again, patients who have upfront brain metastasis and PDL1 score less than 1%, probably they are the best candidate for IUIU regimen. So with this, I want to again thank all my panelists. Special thanks to Dr. Kushal Gupta sir for giving me this opportunity, and my sincere gratitude to Dr. Suma and Dr. Shayan Dash. Thank you, everyone.
So thank you, Dr. Sudeep, for the wonderful discussion. And thank you to all the panelists, Dr. Suma, Dr. Shahan, Dr. Arindam, and Dr. Savinay, who had joined us today. And thank you to all the audience. And thanks once again to the International Association of Integrated Oncologists. With this, we will conclude our academic talk. I don't see any questions in the chat box. With the permission of the organizers, I think we can call it a day.
Sir, as
Thank
we
you.
approach it,
Yeah,
Sir,
over to
can I-
you, Sapna.
yes, sir. As we approach the end of this highly educational webinar, I would like to extend our deepest gratitude to our program director, our exceptional faculty, and insightful panelists for sharing their valuable expertise tonight. A special thank to all our attendees for your active participation. We hope the insights gained today will translate into enriched clinical practices. Thank you, everyone. Have a wonderful evening ahead. Thank you. Good night.
Thank you. Good night.
Thank
Good
you.
night,
Thank
everyone.
you.
Good night. Good night.